Hi, I'm Cathy Sudbury. I'm with Sports Plus Rehab Centers and Lift Therapy. Today we are on the road to recovery to Lift Therapy downtown Jackson. And my special guests today are Brian Thorne, physical therapist, program manager of Lift Therapy, and Andy Akin, physical therapist as well. Today we're going to talk to you guys about manual therapy. It is something that is a huge topic that a lot of people don't realize what our therapists can do and are certified in. Brian, I'm going to let you kind of introduce yourself and Andy today, and let's get talking about manual therapy today.
Thank you, Cathy. Appreciate you guys coming down to talk to us about the Lift Wellness Center and Lift Therapy. A lot of people don't know where we are down here, downtown Jackson. We're right down here in the middle of downtown. Many people are aware of the name Lift Wellness Center. Lift Therapy is a part of that, part of West Tennessee Healthcare. We're excited to talk to you about manual therapy today, what we can offer our patients. So manual therapy is kind of a hands-on approach to physical therapy. Andy Akin is one of my colleagues here we've been working together probably, Andy, 25 years or better?
23, 25, something like that.
Yes, and we might kind of park here and kind of tell how we got interested in therapy real quick and what brought us to today as far as our studies and what we saw in therapy and how we got interested in manual therapy. So first off, maybe Andy, you can tell us, how did you actually get interested in therapy?
With physical therapy itself, I had a knee injury back in college, and I had to have physical therapy, and I really didn't know anything about physical therapy at the time. So I learned about it as I rehab, and I saw, hey, this is something I could be good at, something I'd like to be able to be good at, and these folks are helping me a lot, maybe more than any other healthcare professional I've ever worked with. So that's how I got involved. I wanted to be a part of what was helping me.
So you changed your whole route of career in midstream in college?
Unfortunately, yes. It took me a long way around, but I finally got there, yes.
A lot of people don't know that Andy actually completed a physical therapy assistant program and then got immediately accepted the way the time frames fell right into a physical therapy program. So he had back-to-back schooling, which is kind of unique for a therapist to go from one to the other, just the way the time frames fell right there. So he's actually got double the education that a lot of us have in that area.
Wouldn't recommend it, but that's how I ended up. Yeah.
A lot of tuition dollars behind that too, I'm sure.
So how long have you been practicing? Did you immediately start here with Brian at originally it was Sports Plus Central?
Yeah, I started out at inpatient rehab actually at the hospital for 4 years.
Fourth floor there in the hospital, Jackson General.
And then I went from there to work in with Sports Plus and our manual lymph drainage therapy program, which started out in about 98. I started working with Sports Plus then, and then evolved into working with regular orthopedics around, when was it, Brian? Around 2005 maybe is when I started doing mostly orthopedics with Sports Plus as they were on Roland over there. And we've progressed, or had changed over to, that was before the lift opened. Lift opened up about 2013, and so our whole program from Central moved over there, but that's at that time I was primarily working with orthopedics.
Okay.
Gotcha. So tell us maybe how you've seen things change as far as the tools that you had coming out of therapy school, and therapeutic exercise is the word that we use. Another word that's used is physical medicine. We use physical movement as medicine, as our medicine many times. Tell us about how you had those tools and maybe how you found these other tools of manual therapy. How you got interested in that?
I started seeing people benefit. Everyone was doing therapeutic exercise. We continued to use therapeutic exercise, but I started to see more benefit with the hands-on therapy, whether it be those other colleagues that were doing it or some other professionals that were using manual therapy in other professional healthcare systems. But what I was seeing was more benefit from manual hands-on therapy, and that's when I said, we gotta figure out how to do more hands-on, be more skilled with our hands-on therapy. So over the years, that piqued my interest, and I wanted to learn how to become certified as a manual therapist so I could help as many people as possible.
So you said certified. Would you tell the general public what that means? I mean, it's on top, in addition to becoming a physical therapist, you're continually studying and upping your skills, basically, correct?
Yes, and there's other avenues to manual therapy. The avenue Brian and I chose was Maitland, and that's a type of manual therapy.
It's an Australian-based approach, New Zealand, Australian-based, and then there's a McKinsey technique, which is very popular around this part of the country as well.
And we have both within our system, which is great. So we're able to use it at all the other different locations.
Exactly.
So when you say certified, you go off campus to a course. Is that correct?
That's right. It took us
about 3 years, was it not?
More than that, 4 or 5. It took me a little longer. I think, well, we started together, didn't we?
We did. I think it was about 6 different courses, and each time we go to a course, they kind of recommended that you practice these techniques, not just with each other and review those, but also other people that were in the courses. They're real good about keeping in touch. We would text or email or share things as far as things that would help us, problems that we had, questions that we had, and practice for about 6 months on that at least, and then we'd go to the next course. So it took us 3 years or better to kind of complete those.
But that's the way it's designed,
courses.
correct? The course is that you take like an ABC course, take the first course A, get it, like you said, 6 months practice down pat, and move on to the next. So that is the way the courses are designed to implement, correct?
Yes, and we be one course on the cervical spine or the neck, another one on the lumbar spine, thoracic spine, and then another one on the extremities. So we kind of, as Brian said, we would practice our skills on each other, and then we would, of course, use them on our patients as we were learning. And so we're using them every day, and that kind of helped us polish it and get ready for the next course coming up. And then finally, in 2010, we had the big certification course. We did take a review course, but that's when Brian and I really hit it hard for about 6 months, getting in the clinic, working on each other every day, weekends.
We'd come in early, have coffee before the sun would come up there, 2 or 3 days a week, working on each other, practicing, memorizing techniques. And then as it approached the last 3 or 4 months towards the final exam, we'd come in on some Saturdays and just practice techniques on each other for several hours.
So that was good to have, a colleague that you work with that was going through the same thing as you were. So we were studying the same material, learning it together, and at the same time. So that really helped. It really helped us get ready for the final, which we both passed on the first go, which I'm very proud. That was a very difficult, challenging test, but we had worked for it. We'd studied for it, prepared for it, so we were ready for it. And it had both a manual and a written part, so that was very trying, but we very ready for it. I think we did well on it.
I think of the 40 and 50 that took the exam, whatever. We came in both in the top 5, but Andy beat me.
And this is something you each year you certify yourself. You don't retest, but you still have to keep the certification up. Correct?
Yeah. It's every 5 years that we have to take a recertification course. Which really fortunate because we got to travel to New York 5 years ago, and we got to learn from not only the best but the latest technology, what's going on in manual therapy from the guys that are most knowledgeable about it. Like we studied under a gentleman that's probably known best for his neurodynamics, which is nerve gliding, as we call that, probably the best in the world. I got to sit right next to him, ask him questions.
Chad Cook, I believe is who you're referring to. Is that right?
No, Chad was another gentleman. He's probably the number one guy in orthopedics that we study, and Chad was also there. So we got to hear from the best and know what they're doing in the latest technology. So it was real exciting.
Gotcha. Other things, we just got back from Orlando, where we kind of got to be exposed to a new organization, part of the Maitland extension there, as far as some of their faculty and things. The American Academy of Orthopedic Manual Physical Therapists, that's a mouthful. But they have members worldwide, and so we got to hear people from New Zealand and other parts of Europe, Germany area, and also around our nation and locally. They have a very well-organized organization where they just discuss manual therapy issues and techniques and latest treatments and research in that area. So we're very fortunate the hospital allowed us to go to that a couple months ago. We just got back from that, Orlando.
So now that you guys are well educated, How do we apply this manual therapy? As a general public is listening, is it just back pain? Is it neck pain? What is the specialty that they would need to get this hands-on treatment?
We could tackle both of those very well. Neck pain, we're figuring out just about every American has neck pain now. I mean, everybody we see, everybody has computers. Everybody does computer work. We do computer work. You can't get away from them. Everyone's looking down at their phones all day or their computers. So we've got this new technological neck pain, as we call it. I've noticed that we can do a basis of manual therapy on the neck, and we can also break down that most people have lower neck pain or lower cervical spine pain, and we can mobilize with our manual therapy techniques and then follow up with what we call a stability program, a neck stability program, where they're actually working against the effects of gravity that causes us every day. So just some simple manual therapy techniques followed by some simple therapeutic exercise can help most of the population of neck pain that we have.
So it's something that we should not just accept that we have to live with. There is therapy out there to help these people.
Exactly. And in years past, we would only see patients right before they were about to have neck surgery, which is almost too late. Which really what we would like to get is folks that are beginning to have neck pain, and that's the patient population we can help. And then we can help them a lot better and quicker with our manual therapy, and with some simple exercises. We can get them better in just a few weeks instead of waiting for them to have years of neck pain before they come see us. So yes, we can help them a lot.
One thing, Cathy, that we have kind of talked about with our patients and noticed in the spine is this. The spine is just kind of like a chain or like a necklace. Those links have to all fit together and work together properly. And the patient can move that chain themselves in a certain pattern, a certain way. Sometimes they get themselves in a bind and cause one of those segments to, I'm going to use the word, have a kink in it, if you will. You've heard of the phrase, I have a crick in my neck. And essentially what that would be like is if you had a chain with many links and one of the links became twisted, you might need a little assistance where normal movement that the patient might do cannot get that out in many cases. And that might be a great candidate for therapy, where the therapist can use the manual therapy techniques to go into that kinked segment and just kind of correct that and kind of restore normal movement for the entire chain. Andy, is there anything you'd like to expound on that concept or idea?
Yeah, I think just what Brian said. If we got one or two links or kinks in the chain, that's where our manual therapy technique can really help to mobilize or to loosen up that one link, and then the whole chain moves better. So you got the whole neck. And don't forget the lower back, the middle back below the neck. That's also what we call the thoracic spine. That's also affected by neck pain. So when they can't move their neck very well, they can't move their thoracic spine either. So it kind of parlays into that. We usually treat the upper thoracic spine along with the neck. But a few mobilization techniques can usually get the kinks out of the chain, get them moving better again. Less pain. Now they can exercise. Now they can do some things that they couldn't do, and now we're on our way. And that's where our manual therapy skills can really help. And I want to expound on another thing. Since we mentioned neck pain, we really can't mention neck pain without headaches, and they go hand in hand. Most people think headaches, migraine. Well, most actual studies show that most actual neck pain is not from migraines. It's what we call mechanical neck pain, or headaches from mechanical neck pain coming from the neck. So again, those patients with mechanical neck pain that cause headaches, or cervicogenic headaches as they call it, can benefit very well from manual therapy, from therapeutic exercise, from physical therapy. Now, when it comes to migraines, that's a completely different ballgame. But most, probably 90% or more of people that think they have migraines actually have cervicogenic headaches, which come from the neck. So again, same thing. Most of those are problems with the upper cervical spine. We call the C1, 2, and 3 region. So we can mobilize those. Usually they have some limitations in those upper cervical spine, C1, 2, 3. We can mobilize those, and their headaches usually go away very quickly, and they can get on with some movement patterns, some exercise that normal patients would have.
Yes, when a patient comes in, we ask them, how their pain is behaving, and pain has certain types of behaviors that kind of leads a therapist or a health practitioner to find the source of the pain, because pain behaves in different ways. So if a person is having pain down their arm, all the way from their neck all the way down to their fingers, that leads us back to each nerve root that comes out of the spine is responsible for a certain area. And say in your first two fingers or your last two fingers or the middle of your hand, it can kind of lead the therapist back to the root of that. We know which nerve roots, say like at C5 or 6, the 5th or 6th level of the neck. We know exactly where a patient complains of, thumb pain or tingling or numbness down the first finger or something like that. Can lead us to areas of where that might be coming from with some other testing that we do and evaluation. And as we're treating them, we're kind of mobilizing or moving or testing those segments that might be involved. Many times we can reproduce what the patient, we call it, Maitland calls it their pain. They call it their comparable sign. Mm-hmm. They might call it, what's the slang term they use, the bully.
Yeah.
They'll say, is this your bully segment, so to speak?
Or the culprit.
The culprit, that's right. And so the patient, a lot of times a light bulb will go off and they'll get almost excited, even though we're kind of generating a little bit of pain. But they're like, wait a second, a pain's going down my arm, but you're generating this from that one spot in my neck or my back. Mm-hmm. That's my pain. That's why I'm here. So it's kind of a light bulb moment that maybe we found the root. We know where to go after that. From that point, that really helps us when the patient can describe that. One last thing I'll say about that is Andy was talking about the cervicogenic headache. It's just a headache generated from neck pain. We can do the same type of evaluation, pain behaviors. They may have pain that will refer from the back of their neck, the base of the skull there, around to the front part of one eyeball. They might have some radiating pain that will head that direction from back over the top of their head to the front. And that's from that CO1, the first segment there. That's where that pain referral pattern is. C2 and 3 can kind of come across the same area to the side of the head, and C4 a little bit farther down. But those, wherever they point to where their headache's coming from, and then we kind of mobilize those segments, we can generate that same pain pattern. It kind of leads us to where we need to treat and mobilize a segment that might be stuck or have a kink in it, so to speak.
Well, Brian, would you explain, both of you guys have said mobilize, and explain to the general public that is listening what exactly is mobilization when you're using this term with your patients.
Would you like to take a shot at that, Andrew?
Mobilizing just means moving a segment or a joint. There's different grades of mobilization. Like what Brian was saying, if we have a really, really painful patient or a patient that is pain dominant, we're going to use a smaller grade, which is a grade 1 or 2, which is a very mild movement just to get the segment moving, to get the joint lubricated so it can move easier with less pain. We really like to work on the stiff dominant patients. If they have more stiffness, and like Brian was saying, if they have a stiff, painful joint that we can move, and then they say, "Ow, that's my pain," we can get a patient from pain dominant to stiff dominant. Then we can use the higher grades, the grade 3 and 4, and that just means that we are moving the joint deeper within the structure. And we can get a better movement of that joint, and then as it moves, it gets lubricated more and it moves easier with less pain. Then the whole segment moves easier. Like if it's a neck vertebra, the whole neck can move easier if we mobilize those 1 or 2 bully segments. So mobilizing each individual joint followed by exercise which moves the whole neck is really what we found to work positively with our patients.
Great. That is a great explanation that you're using your hands, that hands-on, and mobilization is basically going in there and finding that 1 or 2, as you call it, little links that are out of place.
Something else, Cathy, that Andy talked about, a stiff dominant versus a pain dominant patient. He mentioned the pain dominant patient, very sensitive. They're in a very acute phase. We have to balance all the medical training and knowledge and the stage of illness that they're going through. So we don't want to over mobilize those areas. We need to use common sense, our medical training, to be gentle, very gentle with those patients until they get and those later stages of healing that the body goes through, and more of a, we call it subacute or chronic, where it kind of calms down basically to where we can do more of the higher grades of motion, the grade 3s, the grade 4s, progressing them in their motion. Those, what we call the stiff dominant, Andy and I get a little excited to work on those. They're kind of more fun because we can use the further grades. They can see a lot more progress faster when we get to that stage, and they'll kind of say it kind of hurts a little, but they'll say it's a good hurt.
Yeah,
it's a good hurt.
They're not hurting as bad. It's a lot easier to work with.
So if it's just stiffness, it's kind of like, oh, that's kind of sore, but that kind of feels good, and I know it's going to be better at the end. So they'll describe it as a good hurt feeling.
So, in your general practice each day, how many patients do you usually see that come in here with these types of back pains or neck pains? Is this because what is it, a percentage? I think they said about 86% of the Americans have lower back pain.
Yes, and we haven't even talked about low back pain yet, which is the predominant patient we see. 8 out of 10 or 80-something% of Americans are going to have low back pain sometime in their life. We can kind of generate that into 3 categories. We got the mechanical back pain, which is kind of like the mechanical neck pain, and most of our patients are going to fit in there. You've got your disc patients that have a pain that radiates, it compresses the nerve root, radiates pain down a leg. That's a little bit more serious condition. And then we have our degenerative disc, our older patients where their discs are degenerating and they've got just kind of a generic pain in their low back and sacral region. But let's address mechanical back pain because that's where most folks fit in, and just about most of our patient population fit into that category. Again, they're going to have a segment that is a bully segment, usually in their lower lumbar region. Usually L4-5 is where we find it. If we can mobilize those joints and get them moving, and maybe find another one up there somewhere that's a bully, that we can get it moving. Again, it's the same as the neck. We can begin to generate movement patterns and therapeutic exercise where they can move freely. Often in the first or second visit, we can start to see some improvement that we wouldn't see before we got these manual therapy skills. We can see success earlier with less pain to the patient. So maybe that can save them a few visits down the road. They don't have to go through therapy quite as long. We can get a little bit more benefit earlier with less pain earlier. That makes the patient happy. That makes us happy. And we can get a lot of success with general mechanical back pain. You have anything to add to that, Brian?
I was just going to say, I'm very fortunate to have Andy here because, if we have a patient that has a challenging case or maybe so painful, and so we call it their nerve roots may be very irritable and inflamed, that can be a tough case sometimes, and it's nice to have Andy to bounce ideas off of. And many times we'll just say, if things are not progressing, we'll just back up and say, what else are we missing here? We like to work closely with the area nurses, doctors, nurse practitioners, anesthesiologists, sometimes physiatrists. Sometimes the patient might need a little help, extra, like a Medrol dose pack, steroids or cortisone, and that's a little bit out of our scope of practice, but we're certainly aware of what they can do to help the patient. So sometimes we'll make a referral out to these areas to get some extra assistance to calm these areas down to where they can progress better in therapy. Mm-hmm. We've seen that through nerve block injections. Not that we do that, but sometimes we see, hey, we have had X, Y, and Z story over here. These patients benefited greatly from that when we sent them out for that referral and came back to us, and we were able to progress them better if things were just too inflamed for us to progress that time.
Mm-hmm.
So how can I become a patient if I have this neck or this back and knee hurting? Do I have to have that physician send me to you?
In most cases, no. You can just call us directly. You can either check us out on the website as far as Lift Wellness Center. Just kind of Google that, or like I said, our phone number as well, 421-6950 is our phone number here, area code 731. And just come to us directly. We'd love to talk to you about, the problems out there that people have. We'll talk through some things, and sometimes we can do it in one visit, sometimes 6, sometimes we'll see, for a month. If we need more, sometimes we can talk to the patient's doctor, their primary care physician, nurse practitioner, and, get some orders if we needed some more. But yeah, you can come directly to us to start some treatment. I can help you get through that. Anything else you have to add to that, Andy?
Direct access is what Brian was talking about. Most insurances allow us to see patients up to 6 visits or longer, depending on how much progress we're making. Of course, we do want to involve the physician if it goes beyond that, or if a patient has a family physician that they're using, we'll be glad to communicate with them, and then we can take it from there. Or if they need further medical assistance, like an X-ray or, like Brian was saying, some medication, we definitely want them to go ahead to their physician and get a referral from them. We'll be glad to communicate with them, or in any way or shape or form. Whenever they go back to their physician, like usually the physician wants to see them in 2 or 3 weeks, we always write a progress report, let them know how they're doing, if they're not progressing or if they're progressing well, or what ideas we may have. So, yeah, we always want to include the physician if possible, but they don't necessarily need one right away. If there's something simple that we can treat, we can usually see them for up to 6 visits, or maybe a few visits longer if we can, like I said, simple mechanical back pain or neck pain or something that we're very familiar with and we can solve without a lot of other medical expenses.
And we try to leave a business card or email, many times even a cell phone, text, anything to where the patient can still get in touch with us if they have problems in the future. We'd like to be a part of their team, or them part of our family. Sometimes in healthcare you can get lost in just the muddiness of not knowing where to start and where to begin. And we're excited to help people through that process, to serve as a consultant, if not just to help them, treat them through that and give them their options of treatment, and just kind of help them in the decision-making process. Not to make that decision for them by any means, but to kind of share them our experience of working in healthcare for 25 years and what's helped people and things we can offer them.
So, Andy, I have a quick question for you.
Okay.
What benefits have you seen since becoming certified in your manual therapy?
Well, a lot. Basically, we're getting patients better quicker with fewer visits, but you really want to make progress in the first visit or two. That's when you get a patient to believe in what we're doing and kind of get them to buy in to physical therapy. So I've noticed I can get pain relief in the first or second visit, which always is beneficial. You want to get some patients some pain relief. They're usually there for pain. If you can get them some pain relief initially, that's going to help us a lot. And so with our manual therapy skills, I can get them relief in the first or second visit. So they're already experiencing pain relief. So we're getting them better, quicker, with less pain, which is always what we're about. The second thing is the patients are coming back to see us if they got another problem. They're asking for us by name. They want to come see us, or they want to bring their aunt or uncle or father or mother, because they've seen the benefit of our manual therapy skills. And lastly, but certainly not least, is that physicians are sending us patients. We're getting patients from as far as 2 hours away. So physicians are believing us. We got a population area where patients are coming in from all over. We've got a lot of counties and communities, and so and there's a lot of places that we can go. But our physicians are sending us patients from far off, and I think that's great. That physicians are believing in us and they want us to see their patients.
One last thing I'd like to add to all this is, I was always been intrigued and interested by the manual therapy techniques that are out there and that people use and why they use them. And I understood the movements. I understood why you would want to use them. I could see the effectiveness from the treatments that we provide to our patients. And then the more we learn about it, the better we get. Just as anything in life, the more you do it, the more you kind of get used to those things and know what you're good at and things you need to work more on. Those skills, we try to practice those. But I actually went through this myself. I guess it's been about a year and a half ago. Real quick story. I fell asleep. My father-in-law paid for us to go to Hawaii, believe it or not. I was like, wow, that's great. I didn't have to pay for that. But anyway, long story short, it's a long flight. I fell asleep, and you're supposed to have those neck pillows to help hold you up. Well, I tried that. It wasn't fitting exactly right. I took it off. I fell asleep with my head tilted to the side for, I don't know, probably 4 hours. And when I woke up, I could not move. I was stuck, and my neck was just killing me. So I went through that. I just kind of made it through with what I could do myself as far as some stretches, exercises, and medicine while I was in Hawaii. I spent a lot of time in the water, so I didn't have to hold my head up. Thank goodness. We did a lot of snorkeling. But then coming back, I just kind of made my way back through the long flight back again. And I tried to treat it myself. I'm a little bit stubborn, I guess. I don't know, if just being a guy, trying to handle it myself. And I got some better, but I actually began to have a little pain. I'm just tingling down my arm, and I still had some neck pain, and I just could not shake it myself. What's the phrase? Physician, heal thyself. I actually tried to get on the traction machine myself, and like I said, I did get better. So long story short, I finally talked to Andy, and he was able to help me through some mobilizations that a person just can't do to themselves. So I had to come ask him for help. I had to humble myself. And once he started doing that, a series of treatments along with the other exercises I was doing, I don't have any trouble now. I don't have any numbness, tingling. So I'm kind of a testimony. I didn't think I would need it, but I did, because I fell asleep on an airplane, of all things.
He's stubborn like that.
Yes, he
we,
is.
We need to. we actually have to work on each other a lot because we got a lot of injuries. So we've seen the benefit of these manual therapy techniques, because we tend to, us as therapists tend to hurt ourselves a lot. I don't know. Maybe it's the part of the game. That's how we got into the game, by being injured somewhere.
This is true.
We ended up treating ourselves a lot. It works.
So as we're wrapping up this session on the manual therapy, I want to thank you guys for coming out and talking to us and allowing us to come down to Lift Therapy. One of the things I want you guys that are listening to pick up on, that manual therapy is a hands-on technique that we provide here with 2 certified therapists. So if you are in need of any type of your lower back, spine, knee, any type of therapy, we are here to take care of you. This has been another edition of We Talk Health.